Hello everybody! Recording live from somewhere. This is Zach Couples with episode number 70 of the Movement Debrief. And tonight, folks, we got one that's pretty fricky dicky good. We're going to talk about, can ribs go out? Short answer, no. But stay tuned because I'll give you a long answer. We're going to talk about terminal knee extension. How you get that last little bit of sauce that you want on your knees when you get them straight and whatnot. Stay tuned. And last but not least, we're going to talk about back surgery. What kind of things should you focus on with people who have had back surgery? These are the questions tonight that are on docket that are asked by the people, answered for the people, by this people, fam recognized fam. Without further ado, let's debrief, shall we? The first question comes from Chad. Chad asks, I had somebody ask me today if your rib can go out. I told them, short answer is no. Can you lead me to more info or give me something in simple terms that I can explain to them? Why, Chad, I can do that for you because I kind of like you. So, Chad, you are absolutely right. To my knowledge, there is no such thing as ribs or joints for that matter going out because there has been no experimental evidence to support that. What you are talking about in scientific terms is subluxation theory. Basically, the thought is that joints go out of place, or we have misalignment or malalignment within joints, not just ribs, but the spine, really anything. It is up to a well-trained manual therapist to put those back into place. The problem is, there's no research supporting this. In fact, I just pulled up a study. I was just reading this a little bit, called Subluxation Dogma or Science. I'll link it in the show notes. But basically they're saying that the same thing. This is chiropractors. A lot of times you see this within chiropractic offices. Although I must also preface that not all chiros think this way. But what they're saying within this article is basically that we have too much dogma, not enough evidence. We're not researching this type of thing, whether or not subluxation matters. All right. Moreover, we also, well, before I dive into that, so basically you have individuals who, in a profession that often says, although it's not just chiros that I'm talking about, because I also know of PTs who think similar thoughts or think that they can fix tears in muscles and whatnot. That's a bunch of baloney. Anyways, you have individuals saying that this is not supported by the literature. We need evidence to make these claims if that is a useful theory. Now, are there times that maybe a rib goes out of place or you have something sublux? Sure. In cases of trauma, absolutely. Shoulder is a common example. Shoulder can sublux or dislocate. Really, any of the joints can. But if you bend forward and all of a sudden, and then you think my back went out or my neck is out of place because I slept wrong, probably not the case. The things I would show people who maybe believe this might be a study such as this. Look, we're showing you that there is no research that this is going on, especially if you have had no trauma. That would be one way you could circumvent that. Another way you could possibly circumvent this from people is by showing them the anatomy. We've all heard someone say, oh, my SI went out. Really? Is that so? Well, then I might point that person to a couple studies, the good study, and I think there's another one. I'll have to link those in the show notes too. Let's see, we got subluxation and the SI joint study. But these two studies showed that basically the SI joint has about 2 degrees of motion, and you show a picture of the anatomy and you want to make sure that the ligaments are included. And it shows the person how robust these structures are. And that's what we really want to create with our people, is not a sense of fragility that you move the wrong way and you go out of place, but the sense of fortitude and resilience that your body is designed in a strong manner to withstand many different forces. The last thing that I would educate your people on is what manual therapy is most likely doing. The subluxation theory, joint goes out, you do a manual technique to put it back in. What contemporary manual therapy research is showing, and I'll link some of my favorites in the show notes, manual therapy mechanisms, is that most likely, most manual therapy methods are working via neurophysiological mechanisms. What we mean by that is that you do a manual technique, and there's probably some changes that occur within your body's endogenous opioid system or pain relieving system. There's other neurochemicals that might be active in the local milieu, and there's also a reduction of some of the threat areas within the brain when you perform a manual technique. In fact, I can't remember the exact study, but when I was doing dry needling, or I took the dry needling course, they had a study where I think the needles were punctured within the individual, and that reduced activity in the basal ganglia, not the basal ganglia, the limbic system, the amygdala. Thank you, the amygdala. So how do we know that that's not the manual therapy mechanism? What's not shown consistently in the research is any local effects, and a joint going in and out of place would be one of those local effects. If there are any local effects, the changes are most likely, I would say, occurring with changes of maybe some of the water or the tissue property, viscoelastic tissue properties. That might be a plausible mechanism, but what we can say is not a plausible mechanism is a joint is going back into place. And if you're wondering about the viscoelastic properties, I'll also link that in the show notes as well. There's a couple studies that I really like, and one of them is Fascial Plasticity by Robert Schleep, that talks about how these manual therapies that we are utilizing may work. And Chad, those are really the things that I try to educate my people on when we're discussing if something can go in or out. And it's not just ribs, but what it also is any joint for that matter. The only time things likely go out or sublux or dislocate is trauma. In the last year alone, I've seen 2 shoulder dislocations happen right before my eyes. And when you see something like that, it's very different than when an individual says, oh, my elbow is out of place. With those people, they have physical signs. They had a traumatic experience occur. Or not even something incredibly traumatic. I had a guy in this clinic, it was insane, I've never seen anything like this. But he had a fall, he had some shoulder pain and whatnot, and then I did some stuff, and he was feeling pretty good. He's like, oh yeah, my shoulder feels good, and he does this, and then, had a sulcus sign. Like, holy crap, that was crazy. But again, even in that person's case, he had previous trauma to the shoulder, and it's probably that he came in here, we did some wonderful techniques, he was feeling pretty good, muscle guarding decreased, allowed the subluxation or the dislocation to occur. So those are the stories that I would most likely tell someone, Chad. I also think from a clinical standpoint, we have to understand that context matters. With people who think that a rib goes out of place or their neck goes out of place, we can't blame our patients and clients for thinking this, because they're trying to find a story of some sort to make sense of what happened. We all do this. I'm seeing Ben House for some gut related stuff. And I'm trying to make a story as well in terms of why this is happening. But then stay tuned for the answer for a blog later on. But even though I had this preconceived notion in terms of why I was getting some symptoms, Ben squashed that. We have to do the same thing with our people. And if they're uncertain what's going on, and they've heard something like a subluxation might be a thing, that could be a plausible way to explain what just happened. And we just have to educate them that that's not. A pop in one context could be incredibly threatening. Let's say a pop when you're getting a joint manipulation, that could feel amazing. It's the same noise, but we have different stories to explain that out. To summarize, Chad, The ways I squash ribs going out, because that doesn't likely happen, is let them know joints typically only dislocate or sublux under trauma. Show them the anatomy, show them how robust the human body is, show them some of the research showing that, hey, this is probably not a proven theory. And also explain to them how manual therapy probably works. Because if they have a practitioner they go to who's putting them back into place, well, that practitioner probably needs to get updated with the science. But if you do those things, Chad, you educate your people, you hear them out and give them a more relevant story than maybe the subluxation story, you ought to be in business. Chad, great question, my friend. The next question comes from Jeff. And Jeff asks, good day, Zach. Really enjoy your content and podcasts. Thanks for putting up great work. My pleasure. Had a question that I understand may be challenging, not given a comprehensive screening done by you personally, but do you have ideas for achieving terminal knee extension in a collegiate post-op ACL client? Patellar graft. Thank you if you have any insight. Jeff, solid question. And I may have some insight. Terminal knee extension. What needs to happen? Well, let's grab the femur. As the knee bends and the knee straightens, there is a degree of rotation that ought to occur. This is called the screw home mechanism. Screw it. When your knee straightens, there should be a little bit of tibial external rotation. It has to do with some of the anatomical groove that occurs within the femur and tibial relationship. So we should have tibial ER upon straightening. As we bend, that should unlock and go into a little bit of tibial IR with the bend. Today, we're focusing on 7/8 lane straight, if you know what I'm sizzling. Things that I focus on to restore that last little bit of knee extension actually don't happen at the knee until later. First and foremost, we have to make sure that we have movement variability or variance, I don't care what you call it, up here at the hip. If you don't have that, you're not going to get much down here, because guess what? You got your hamstrings and they attach up in the hip and the pelvis. You got quadzilla, that also attaches at the hip and the pelvis. If you lack variance in that area, that is likely going to alter the contractile properties of those muscles, which impact your ability to straighten your knee. Hopefully not that much. So that's the first line of defense. How do you want to restore that? Well, I'm glad you asked. Because what we're going to do is make sure we get all directions at the hip taken care of. Start with hip extension, which is muy importante. And I have an entire debrief. I can't talk today. I have an entire debrief linked on how to do that. You want to go with extension. You want to go with your frontal plane measures, adduction, abduction. I also have a debrief link for that in terms of how I do it. I'll link all the hip debriefs that I've discussed. And then, of course, making sure you restore rotation, both ER and IR. And I think I have some debriefs for that as well. That's the first line of defense in terms of what you want to go after. Because if you don't have that, chances are you're going to alter the line of pull, the hamstrings, and potentially the quads. So maybe some might be more concentrically oriented than others. And that could negatively impact the ability to get terminal knee extension. Moreover, think about it this way. Me getting that tibial external rotation to achieve terminal knee extension can also occur by restoring hip internal rotation. Those two things go hand in hand. So if you have someone who can't get hip IR, chances are they're probably not going to get terminal knee extension. So these are important things for us to restore and improve upon. And sorry, I just want to focus a little bit better. That's worse. Let me do that again. I'm still ugly either way, but we'll work with it. So, first line of defense, get the hip loosened up. You'll be closer to business. Once we've done that, we may have to do some local things at the knee. Well, actually, before we go there, I usually do the knee last, because I also want to make sure that I have ankle dorsiflexion available. The gastrocnemius is a knee flexor. If I have an ankle dorsiflexion restriction, that could potentially also impact knee extension. Working on squatting, working on full gait patterns, some of the stride variations that I've utilized, I'll link some of those in the show notes. Well, gosh, these might be the best show notes ever, which will be available on zachcoaches.com tomorrow. Stride variations in standing, those are really good. Those are all things that I use to try to get ankle dorsiflexion restored. That'd be another important piece to consider. The last piece that I would consider is actually doing stuff to the knee. In terms of gliding, when I go into knee extension, I ought to achieve somewhat of an anterior glide of the tibia, and I also need that external rotation. In order for me to drive an anterior glide, I kind of sort of have to make sure that I don't get too much hamstring, because guess what? The hamstring limits the amount of anterior glide. It is the muscular version of your ACL. Very important for your client, Jeff, who has a new ACL in this case. But when you're working on restoring hip motion, you're probably getting them hammed like bacon, if I'm not mistaken, already. So it's time to get a little bit of quad. What I like in this case, and I got this idea from Daddy-O Pops Bill Hartman, is putting the hamstrings at a mechanical disadvantage and contracting the quad from that position. What that would entail is maximally flexing the knee, so you get a degree of active insufficiency of the hamstring. Maybe either you can IR the femur or ER the tibia, and I would probably in this case IR the femur, and then work on active knee extensions from that position. Because what will happen is the hamstrings won't have leverage to limit the anterior glide. Quads will have leverage. So then you can do that little technique and boom, you're probably going to get yourself terminal knee extension. And that's really the order that I would address that in. Oftentimes, if you take care of the hip, the terminal knee extension comes back pretty quick. Rarely do I anymore do much local inputs to the knee until I make certain that the proximal and distal structures in this case are taken care of, because they have such a profound influence on what the knee is doing. I can't remember who said this, but it's a truism that I think is very effective. The knee's kind of a dumb joint. It either does what the hip tells it to do or the foot, and you should practice your approach accordingly. So to summarize, if you want to get terminal knee extension back, get the hips loosened up, make sure you get extension back, especially IR, since hip IR equals tibial ER equals terminal knee extension gains. Once you've done that, you want to make sure you have an ankle dorsiflexion as well, both with the knee flexed and knee extended, because you got to get that gastroc chilling, if you know what I'm sizzling. And last but not least, then we can go on restoring terminal knee extension. What I like to do, maximally flex the knee to make the hamstrings at a disadvantage, IR the femur, work on knee extension, get them quads on fleek, and you ought to be in business. Jeff, great question. Before I dive into the last question, if you have people who hurt multiple areas and you're unsure where to start, or you've been coaching people doing their rows and they're reaching and they're doing that weird thing where the elbow goes too far back and they say my shoulder hurts, well, guess what, folks? I have an answer for you, and the answer is Human Matrix, and it is coming your way February 2nd and 3rd in New Jersey. Why do I keep forgetting the name of this place? Man, it's killing me. New Providence, New Jersey. That's what it is. New Providence, New Jersey. There will be other Human Matrices announced, hopefully in the next few weeks. There's going to be quite a few of them, so I hope to see all of the fam there. And right after that, that one's February 2nd and 3rd, but the 9th and 10th of February, you have myself, Pat Davidson, yes, the Pat Davidson, and Seth Oberst, yes, the Seth Oberst, that guy. We are going to be in Boston the following week, February 8th and 9th, for the revolution. It will not be televised. It is here. I hope to see you all there. Please sign up. I will link that in the show notes also. But without further ado, the last question comes from my girl, Kelly. Kelly asks, there are so many people who I am seeing that have already had 2 to 4 back surgeries. And I wonder if I'm just spinning my wheels trying to do breathing / corrective stuff with them. Is it worth spending time on that for these people? Kelly, that's a great question. And the answer, gotta tell you, is an emphatic yes. It is worth it for these people. Here's why I think it's worth it for these people. One, man, I really got to get this. I'm going to just get in close. How about that? One reason why it's important is we have to understand potential contributing factors that got them there, right? A loss of movement capabilities, maybe in that region, eroded some of the tissues in there. Problems ensue. And also, if you're working with people in fusions, they have probably lost a degree of variance due to the structural changes that have happened secondary to the surgery. Those areas can't move as well. Your objective is to restore movement options at the areas that they can move. If you can do that, my thought is that can take off some of the pressure on the lower back because you have more tissues available to perform some of the tasks that those individuals need to do to be able to live life. If you do that, that could potentially help them with pain. I also think that a lot of the breathing-based work and early corrective activities that we utilize with our people, that's super low intensity. Most of these people who have gotten to the point where they have back surgery, I hope. Sometimes we had some people who had just local low back pain here, not at this hospital system, but here, who had surgery right away. Crazy. But a lot of times these people have been hurting for a long period of time, and they've probably become deconditioned in the process. And a mistake that I often make with this population, as well as some others, is doing too much too soon, or too intense too soon. The threat responses or stress responses within these people is elevated. If it's elevated, sometimes if you throw a little bit of too much sauce on them too soon, you could create a flare-up that's going to impact your buy-in, that's going to make them sore, that's going to set them back. We don't want that. But if we do breath work or corrective activities, that is a little bit more of an activity that we can throw under the radar that might be incredibly impactful for these people. So I think it's incredibly important. Moreover, what we forget, and I've been telling my clients a lot more this, especially if they have low back pain, is your diaphragm muscle actually attaches to most of your lower back. What if you have an inability to take that muscle and have it go through its full excursion, i.e. mobilizing the rib cage to and from, making sure you have full bucket handle, pump handle, and posterior thorax capabilities? Don't you think that might alter what's going on in your lower back region? So I think it's incredibly important. And what I think is really cool with this population in particular, and where I think you're probably struggling, Kelly, is slowing down with these specific people. And really not that, but all people. Do they have the basics in place? Can they get a full exhalation? Can they generate some abdominal tension? A lot of times people who've had spinal fusions or other back surgeries, that's a struggle for them. So can they get that? Can they keep that tension there while they're inhaling? You might be able to spend a few sessions working on that. And it's really a low stress activity, so the chances of you creating a flare-up is not necessarily that high. I think that it would be a great activity for you to do with those people. Is it the only thing you want to do? No, of course not. There's decent research out there, I believe at least, that shows that people who are in persistent pain or chronic pain, or especially back surgery, aerobic exercise is paramount for helping these people from a pain perspective. There's a lot of good beneficial things that happen with aerobic exercise. I'll link some of the studies that I've come across in the show notes, but that could be another thing that you may employ for someone who has a spinal surgery. When I'm working with people post-op in this regard, that's really the two-phase approach. Start them slow from a corrective standpoint, and also start them slow from an aerobic standpoint. Maybe their aerobic exercise is just walking a lap around the house to start, and maybe their breathing activity is just sitting and breathing and working on generating some tension with an exhalation. But I found more often than not that if you make sure that the basics are coached savagely well with this population in particular, you won't be spinning your wheels, and you're going to be helping them get better, in a much better place than they probably were pre-surgery. So to summarize, Kelly, yes, breathing is impactful for this population. Just slow cook it. Make sure that you are focusing on the specific mechanics. You're making sure they can generate tension within their abdominals via an exhalation and maintain it with an inhalation. And if you throw a little bit of aerobic exercise on them as well, that will often help them more often than not. But I understand your frustrations. It's a lot of 2 steps forward, 1 step back kind of thing. But just go slow, take your time, stay the course, and you will help them. Great question, Kelly. I think that's a good stopping point for us tonight. I want to thank everyone so much for tuning in. If you want to learn more about Big Z, who doesn't? I'm sure most people don't. But if you want to learn more about Big Z and where to find me and where to find out more information, here's where you want to go. First, go to zachcouples.com. You'll want to sign up for my newsletter. I have 4.5 hours worth of free talking material. 3 of them, I believe, are on breathing, an hour and a half on pain. Pretty impactful stuff. I hope you give it a shot, give it a listen. Wait. Lauren, great question. In terms of books to go that talk about infrasternal angle, the only one that I'm aware of is Shirley Sarman. I'll link her in the show notes. So go there. You'll also get a free acute to chronic workload calculator, which can help you progress people in a reasonable manner with activities while minimizing a chance for an injury. You'll also want to sign up because every Friday you're going to get weekend goodies from me. If you want to know what's dope on the internet, I'm your guy. Definitely check out zachcouples.com. In that regard, I also offer services, 3 of them, yes, 3. We offer movement consultations. If you're toying and not moving as well as you'd like to, I'll take you through a movement consultation. We'll do exactly what I talked about with the TKE thing, terminal knee extension. We'll find out what moves you can't do, give you a little something to improve that, lead you on your way. Definitely hit me up for a movement consultation. I also offer mentoring. Maybe you want to go through how to restore terminal knee extension on a case-by-case basis. We'll talk through the nitty-gritty. I'll show you how to get it done, and you'll be in business. Definitely hit me up for mentoring. I also offer online training if you want straight-up gains, or maybe you're post-rehab and you just, you want to start training and you're unsure where to start. I could be your guy. Definitely hit me up for that. Once you've scoured zachcouples.com, you may want to go to iTunes or Stitcher, search the Zach Couples Show, bring me on a car ride, because guess what, folks? There's 69 other debriefs. You probably don't want to look at me for all of them. Maybe you want to give me a listen. Definitely look me up, the Zach Couples Show on iTunes and Stitcher. Please leave a review so we can let the fam grow. Last places you can find me, social media. I'm trying to be a little bit less on there, but I'm still there occasionally. Facebook /Zeke Couples. Twitter handle is @ZekeCouples. The Instagram baby is Zach, ZAC Couples, CUPPLES. And last but not least, find me on YouTube. Just search Zach Couples. I'll be there. I want to thank you all so much for tuning in. Keep it real, but not to the extent when things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.